Well, welcome. This is Texas State Senator Bob Hall, and we're going to be talking about the COVID and what our medical doctors are doing to address this issue and their successes. And many of you have seen our previous video that we put out that's been very popular, talking with 6 other doctors. And today I've got Dr. Amy Offutt from out in the Marble Falls area, who has also been treating patients in her practice and has found a lot of success. She sent me a diagram of her protocol, which is very similar to other doctors with her own personal approach to it, of whether people are symptomatic or asymptomatic or high risk. And she has been using this and getting great results. And so I've asked her to join me here today and tell you about what she's doing and how she's going about it and why she thinks this is the answer to moving from a defensive strategy of just mask and lockdowns and isolation to one of actually fighting the COVID in an offensive way. So Amy, welcome. Glad you were able to join us today.
Thank you, Senator Hall. It's an honor to get to talk to you. And I debated whether to actually participate in this or not, because there are some personal fears about putting myself out there. However, I have strong faith and I prayed about it, and the resounding answer I keep getting is that I need to share with other doctors, especially, that treatment is a good option. And there's really no reason beyond the usual reasons for treating patients to withhold treatment. And I think that's what is unfortunately happening right now.
And I want to thank you for that, Amy. I do know. And guys watching this, I hope you heard what Amy said, because it is a risk to her, because we have a very dysfunctional Texas Medical Board and Pharmacy Board here in Texas. And these doctors are putting themselves in jeopardy because of the politics, not because of the medicine, not because they're doing anything that harms a patient or is improper or not in line with general accepted medical practices, but simply because it's a political issue, that there are forces out there that don't want you to know that there are medical solutions to this. They want you to think that the only answer is going to come sometime in the far distant future with a vaccine that I don't think any of us want to wait for, or not wait for, or even to take. And so I have to thank you, Amy, for having the courage. And I know that you prayed about this. I pray about it every day, because I know I've put myself out there, but that's all been done now. I can't take that back. And so I'm in the fight to the end. And I appreciate you joining with us.
Well, I had some amazing mentors in my training who taught me that if I always focus on the patient, I'm doing the right thing. So that's my focus. And I think that's a common theme amongst a lot of Texas doctors. We focus on our patients. And, you know, for me, it isn't political. I know I have patients that have argued with me even on that. But when someone comes in and they're not feeling well, or calls and they're not feeling well, or has a medical problem, I don't ask them what politics they follow, or, I mean, it's not about that. It's about what tools do we have? What tools can we use? What can we do to be helpful, encouraging, supportive? And even with the things I'm doing right now, I still give the patients the same precautions. Like, I've treated 30 patients so far with COVID, and one went to the hospital, and it was because he didn't want to wear oxygen at home. He was in the hospital for 3 days on oxygen, and then he went home on oxygen and recovered fully. Other than him, who presented very late, none of the other patients have gone to the hospital. And you know, I don't have where I am a population of sick patients like, say, in Houston or the Dallas area, but I feel called to tend to the patients presented to me with the tools that I have in my toolbox to treat and take care of them. And I think other doctors could be doing the same without fearing negative consequences, as long as they're just focused on the patient and the patient's health. And I would encourage other doctors to use the tools they already know. Like the things I'm using, I've used before. I know what they are. I know how they work. I know how they match with other medications. And I'm happy to share the protocols I've been using with anyone that wants them. Some of the things I do may be different. Some of the things will be the same. But if each doctor takes from the list of possibilities what they feel comfortable with, and then offers that to a patient who's sick with this virus, and still tells the patient, if you become short of breath or you become, incapacitated, obviously call 911 or go to the hospital. This is not to negate that option. It's to try to prevent that from happening. And if we focus on prevention, early treatment with the tools that we do have, every decision I've ever made as a doctor is a balance of risk and benefit, risk, benefit, risk, benefit. If I start someone on a blood pressure medicine, I ask myself, what are the potential side effects? What are the risks? What are the benefits? If it doesn't work, I try something else. It's honestly not different than what we already do as physicians. It's just new, and it's, the television has actually created so much angst and fear. And most of what the television presents or the internet is anecdotal. We talk about, double-blinded, placebo-controlled, randomized trials and not using anecdotal data to treat our patients. But what's on television is anecdotal. The story of someone who dies, it's dramatized, it's emphasized, it's made to create more fear. And I have been noticing in my patients, a lot of our phone calls are anxiety or sleeplessness or headaches or digestive problems because of all these fears. And I've sort of lined it out that one end of the population is fearful of dying. The other end of the population is fearful of losing liberty and freedom to go out and do. And so when we're all in a fear state, we're somewhat at our worst as far as being reactive or edgy toward each other. And somewhere in the middle of being realistic, reasonable, having common sense, using logic, is where I feel like the doctors could play a really important role in moving forward and getting past where we are right now. Because we can reassure our patients, we can educate our patients, we can take care of our patients, and then they have a less likelihood of having serious illness. And then once enough people know, half a dozen or 10 or 20 people who've had the virus and recovered, we can start to relax a little bit and understand more what it's really like to have the virus, as opposed to the television version of what most people have just been sitting in their homes and watching for months.
Yes, and the information, you're absolutely right. The disinformation out there is example, the study that was done in the VA hospital that was publicized so heavily that they said, oh, hydroxychloroquine doesn't work, it killed the patients. Well, it turns out that in the VA home, there was no real control of it. They gave them very high doses, right near, they were almost dying. They're close to dying when they gave it to them, very high doses. And hydroxychloroquine, like anything else, you give too much, too much aspirin and you will die. And that's exactly what was happening. We went back, and as I was studying the literature, the stories about, the problems that people had with their heart and things like that, those were stories that were 50 years old when they were first started using it. We're upping the dose. This thing we have, if 1 pound works, we try 3 pounds. And obviously that's what they were doing. And they found that didn't work. That did not work, and it caused heart problems. And so they stopped doing it. But they stopped that 50 years ago. And they talked it in the doses of, I believe, 200 milligrams or 400 milligrams a day is as safe as taking a baby aspirin in there.
Well, even just today, we had a patient who does take some cardiac meds and has a pacemaker, has had some arrhythmias, and we selected something different for that patient. So it's the same thing we do. We look at each patient's, personal individual health. We make assessments. We choose interventions that are risk benefit based. And especially right now, when there's not anything being done for most who have this, except for go to the hospital, get tested. If you're not hypoxic, you go home and wait to either get well, suffer, or get more hypoxic and go back to the ER. Like if that's all we have, obviously the risk of that could be overshadowed by the potential benefit of some sort of early intervention. So selecting the right medicine is honestly a fairly simple, straightforward strategy for most physicians who treat patients day in and day out for whatever ails them. So, you know, I'm not sure why that simple logic has flown out the window right now, but I'm just taking care of each patient in front of me as they present and then watching the results. And that's what I've done for 20 years. I've been a doctor here for 20 years. And it's really no different than the normal doctoring. It's just done with maybe not as much peer support, but I don't know that we couldn't get there if we had a few more doctors start actually deciding to do some treatments.
Oh, I think we absolutely could. And what I was impressed with is when you first contacted us, you sent your protocols that you did, the way you approach it, which is very logical, the way you've just described it. And I know the treatments will vary somewhat from this, but in general, you divided it into symptomatic and asymptomatic and low risk and high risk. Would you like to walk us through your flow chart and your approach of a symptomatic patient?
Sure. So if someone's symptomatic, the first thing we would want to do is test. I have tested everyone that I could. I will say I have treated a few spouses who were symptomatic, whose husband or wife had a positive test as well. Like that's again, common logic. But as soon as I know someone is symptomatic and then positive, I will stratify that particular patient into low risk or high risk. The low risk patients obviously will need a little less supportive intervention, but based on their symptoms, I would place them on a few nutritional supportive supplements. I would consider putting them on a nebulizer protocol. I have one nebulizer protocol that's actually not prescription medication based. That's very inexpensive. There are other doctors in the United States who have used it extensively for years. And there was a published paper for 107 COVID cases using this actual recipe in a nebulizer formula that doesn't require any prescription. It's dirt cheap. Anyone could order it all on Amazon and have it at home. And I'm not touting it as the cure by itself, but certainly for someone who's low risk, who thinks they may have been exposed, to have that tool at home to administer to themselves or their family members could be helpful. So that's in my protocol as a low risk intervention that's possible.